So, dear audience, welcome. My name is Mariangela Pellegrini. I work for the ERN-EuroBloodNet as Patients and Education Program Manager. And it's my great pleasure to invite all of you on behalf of the ERN to this webinar program for patients and their family tackling sickle cell disease. As you may know, the topic of this webinar program, because it's a program that consists in 11 webinar sessions, have been chosen by the patients community itself, because we circulate a survey asking which educational topic they would like to discover and having more information, and genetic counseling is one of those topics chosen by patients. This is the 7th session, as said, of a cycle of a comprehensive program. And today we are going to talk, as said, about genetic counseling. With us, there is the Dr. Celeste Bento, who is a molecular geneticist, and she's also the coordinator of the congenital red blood cell disease laboratory at the hospital in Coimbra in Portugal, and of course an ERN-EuroBloodNet member. Her areas of interest are, of course, red blood cell disorder and hemoglobinopathies. And she's also very involved with patients advocate. I myself, she always help us when we create or coordinate new projects for patients and with patients. And indeed, she's member of the board of the Portuguese Association for Patients with Hemoglobinopathies, that I cannot say it in Portuguese, but the acronym is APPDH, that is like patients with sickle cell disease, Portuguese patients with sickle cell disease. Celeste will tell us how it is named in Portuguese. So Celeste, the floor is yours. Thank you very much.
Okay, thank you, Mariangela, for the presentation. And I'm going to tell the name of the Portuguese Association is Associação Portuguesa de Pais e Doentes com Hemoglobinopatias. So it's not, it's not only for sickle cell disease, it's for all the hemoglobinopathies. Okay, first I would like to thank you for inviting me to come here and speak. It's a pleasure to speak for the patients, and I hope that they understand me. I try to
sorry, Celeste, we lost you for a moment.
Okay.
No.
Now
yes,
I am
right,
here.
yes.
Okay. So it's a pleasure to be here. I'm going to talk about genetic counseling. And I'm not able, yes. Here are the rules. I don't know if you want to say the rules, Mariangela.
And
but...
yes, I can tell them because I forgot to tell them, so thank you. The PowerPoint is not scrolling, so maybe I can suggest to share it as sharing the screen and not sharing the PowerPoint, because it's easier.
You are not looking to the second slide?
No, it's stopped at the first and it's not in presentation mode.
Oh.
So maybe you can go out and entering. Yes, I would say sharing the screen is better. And in the meanwhile, yes, I forgot to tell our house rules. Thank you for remembering me. So first of all, this session is recorded because the video will be available on YouTube and our e-learning platform. So of course, if you feel not comfortable with us, with this, switch off your camera, and then your microphone will be muted along all the presentation. But at the end of the presentation, there is the possibility to address the question. You can both write them in the chat, or you will have the possibility at that moment to unmute and ask the question. So it's still not in presentation mode.
No?
No. But you can scroll them because we are able to see the slide,
Yes.
even if not in, but it doesn't work for us. Maybe shall I share the PowerPoint? Or if you can try again, but sharing the screen, not the PowerPoint. Yes, now.
Yes.
Yes.
But I can't.
Yes.
Now it's working?
It's going. Yes, yes,
Okay,
great.
good.
Great, thank you.
So I have no conflicts to declare, and I'm going to start. Okay, this is a webinar for patients. So I would like to know why are you interested in genetic counseling for sickle cell diseases? Maybe because you are a carrier of hemoglobin C, S, that is a sickle cell trait, or maybe because you are a person with sickle cell disease, or a familiar or a friend, you have a familiar or a friend with sickle cell disorder, or you can be a couple at risk for sickle cell disease, or maybe you don't know if you are a carrier or no, you are a young people that wants to know if you are a carrier of sickle cell disease and you want to know how to be tested, or just you want to learn more about genetics of sickle cell disorders. Okay, and this webinar on genetic counseling, I hope that at the end of this webinar, you will be able to understand the genetic basis and pattern of inheritance of sickle cell disease, understand how and who should be diagnosed or tested for sickle cell trait, and be aware of the importance of identification of couples at risk for sickle cell disease and their options. Okay, and by definition, what is sickle cell disease? Sickle cell disease is a genetic disorder, you know, that affects the red blood cells, the erythrocyte, causing them to become sickle or crescent shape, or like someone said, like a half moon. The erythrocyte, the normal erythrocyte or the healthy red blood cells are round shaped. They are very beautiful, as you can see in this figure, and they move through small blood vessels to carry oxygen to all parts of the body. The role of the red blood cell is to carry oxygen to the body. And when you have sickle cell disorders, what happens? The red blood cells that work very well, they are sick, and the sickle cells die early, which causes anemia. And also when they travel through small blood vessels, they get stuck and clog the blood flow, and this causes strong pain and other serious complications, such as infections, acute chest syndrome, and stroke. So you already know, sickle cell disease is a severe disorder. Okay, let's start with the red blood cell. Red blood cell is a small cell, is one of the components of the blood. Without nucleus, this cell has only 3 major components. One of them is the membrane. It's a complex of proteins. And the role of the membrane is give shape of the red blood cell and the flexibility. The red blood cell have also enzymes to do the energy and maintain the balance of the red blood cells. But the main component of the red blood cell is hemoglobin. Hemoglobin is a protein that carries oxygen. And in fact, okay, sickle cell is a problem of the red blood cell. But who is the culprit? The membrane? The enzymes? No, it's of course, hemoglobin. The problem is in hemoglobin. So let's see what is hemoglobin. Hemoglobin is a molecule made of hemoglobin chains, 4 chains of hemoglobin equal 2 by 2. 2 of them are alpha chains and 2 of them are non-alpha chains. In normal adults, the main form of hemoglobin is hemoglobin A. And hemoglobin A is composed by 2 alpha chains and 2 beta chains. Another form of hemoglobin that occurs in the fetus is hemoglobin F. Hemoglobin F is made of alpha chains, but instead of beta, they have gamma, is alpha 2, gamma 2. When you have a sickle hemoglobin, you have hemoglobin S. You don't have the normal hemoglobin A, but you have hemoglobin S. And the hemoglobin S is composed by 2 alpha chains and 2 abnormal beta chains that we call beta S. So in all of these hemoglobins, as you can see, the alpha chain is normal, is the same. The difference is in the beta chains. So we have here the second culprit is the beta, are the beta chains. The beta chains are proteins, and like proteins, they must be synthesized by genes. And the gene that is responsible for the synthesis of beta globin gene is the HBB gene. Okay, and all the problems are, in fact, in the HBB gene. And what is the HBB gene? It is located in chromosome 11, and it's in a part of the chromosome that comprises a family of genes that are associated with the production of hemoglobin. Here you have the genes for gamma, the chains of the fetal hemoglobin, the gene for a minor form hemoglobin, it's called hemoglobin A2, and the HBB gene for the beta chains. And what is a gene? A gene is a part of the DNA, and it's made with a lot of a successive sequence of letters that we call nucleotides. They are nucleotides and have only 4 different nucleotides. Nucleotides A, C, G, and T. Only 4 letters in sequence that made a gene and that have all the information to make a protein. And here is represented the gene, the HBB gene, and what happens in the hemoglobin S. In this large amount of letters, an A is changed by a T, and only this makes the sickle cell disease. So you have in hemoglobin A the normal gene, the HBB, and in the 20 nucleotide, you have an A. It's normal. When you have hemoglobin S, it's because in the HBB gene, in the 20 position, instead of an A, you have a T. So in the protein, you have an amino acid, and instead of glutamine in position 7, you have a valine. And this is what makes the hemoglobin S. Okay, I think now you can understand the genetic basis of the sickle cell. It's a mutation in the HBB gene, but you have to understand the pattern of inheritance. Okay, human cell contains 23 pairs of chromosomes. Here they are represented. 22 of them are equal, and they are called autosomes, and 2 of them are the sex chromosomes. In these pairs, in each of the pairs, one chromosome is inherited from the mother and the other chromosome is inherited from the father. In the case of sickle cell disease or HBB gene, as I said, is located in chromosome 11. So we have one HBB gene inherited from the mother and another HBB gene inherited from the father. Here I represent the HBB gene inherited from the mother in pink and the paternal in blue, just to understand. And here are the different forms that you can have. Okay, in this case, the HBB gene is normal. You have the A, and in this case also, the HBB gene inherited from the father is normal. So this individual is homozygous normal. When both of the genes are equal, we say they are homozygous. And it's not homozygous normal, we will have only hemoglobin A. In this case, this individual inherited from the mother a mutated gene and from the father a normal gene. And is the same, I put it in duplicate, but is exactly the same if the mutated gene is inherited from the father or from the mother. The result is the same. You have an heterozygous with both hemoglobin A and hemoglobin S. These individuals are normal. They don't have sickle cell disease. In this case, this individual inherited the mutated allele from the mother and the mutated from the father. Both of the genes have the mutation, is homozygous. Homozygous for hemoglobin S or SS. So is a sickle cell disease. When a disease must have the two genes, the two chromosomes mutated to become a disorder, we said that it is autosomic recessive. Autosomic because is in one of the 22 chromosomes that are equal, and recessive because it needs that the two genes are mutated to have the disease. But the sickle cell disease is not made only by homozygous hemoglobin S. There can be other combinations because one of the genes can have the hemoglobin S. In all the cases, hemoglobin S must be present in one of the genes, but in the other genes, we can have different conditions. In this case, I will represent a condition when the gene doesn't work. There are no production of beta chains in this gene. It's a condition called beta thalassemia. In this case, this individual have one chromosome inherited. One of the chromosomes inherited the hemoglobin S gene, and the other inherited a gene for hemoglobin C. In this case, you have hemoglobin D, in this case, hemoglobin E. They are different forms of hemoglobins, but the result is the same. These individuals have sickle cell disease. And there are other combinations of hemoglobins that I'm not going to talk because there are a lot of them. Here are represented only the most frequent. So I hope that now you will already understand genetic basis and the pattern of inheritance of sickle cell disease, that is a recessive disorder. And now let's go to see who and how should be done the diagnosis of sickle cell trait. Okay, every people in the world can be a carrier of an hemoglobinopathy because the carriers are normal persons without symptoms, without a disease. So to do the test of the carriers, you must do both two different tests. An hemogram, always necessary. Hemoglobin S usually have normal hematological parameters, usually, but sometimes they can have anemia and hypochromic microcytic RBC, red blood cells. This means that the red blood cells are shorter and without color. And you must do also an hemoglobin study with quantification and identification of the hemoglobin variant. Sorry. Okay, and how can be done the hemoglobin study? With an HPLC, we can see the different fractions of hemoglobin that you have in your blood. Usually you only have hemoglobin A, but if you have an hemoglobin S, you can see it by HPLC. Or you can use another methodology that is capillary electrophoresis, when it's also possible to see hemoglobin S. And here is an old technology, but still working, called isoelectric focusing, that it's also very good to separate between hemoglobin S and hemoglobin A. But as I said, you must detect not only the hemoglobin S carriers, but also the carriers of the other diseases like the beta thalassemia. And to detect the beta thalassemia carriers, you need to do a hemogram, because carriers of beta thalassemia can have normal or low hemoglobin levels, but have always a low MCV and MCH. And also the hemoglobin A2, the small fraction of hemoglobin, must be below 2 to above 3.5%, sorry. And here you have the one HPLC with a high value of hemoglobin. So it's to detect the beta thalassemia carriers. But you can do the same to detect other variants like hemoglobin D, hemoglobin C. All of them have different patterns in the HPLC. There are sometimes variants that are silent in the HPLC, and you must do molecular studies. So who should be tested? Sickle cell trait is one of the most common hemoglobin mutations in the world because of its protective effects against malaria. So here you have the world map, and the prevalence of hemoglobin S is coincident with the prevalence of malaria. So you look at this map and you can say, okay, so I only have to test the people from these areas of the world. But first, there are lots of immigration, and maybe the map it's not like this anymore. But at the same time, you have other hemoglobinopathies, like the beta thalassemia. And here you have the distribution of the beta thal in the world. And as you can see, it's almost all the world, except Africa, or in some regions in Africa, where hemoglobin S is frequent. So you have to test all the world. And the screening should be universal for all the people and should be done at the age of 13 to 18 years old or at the preconception counseling. So now you know how and who should be tested. And now let's see what happens with the couples at risk for SCD. You have done the test and you know that you are a carrier. Now what can you do? People with a trait, people that are heterozygous for hemoglobin S doesn't have symptoms, they are healthy, but they can pass the trait for their children. So when you start planning to have a child, your partner should be tested for hemoglobin S and other hemoglobinopathies. So the tests that I talked before, hemogram and hemoglobin study must be done. Okay, and what are the options? Both of them are carriers. So you are a carrier, you are AS, and your partner do the study and is normal without hemoglobin S. So is a couple without risk. What can happen is that you have children like you, carriers, but without risk. Or your partner is also an AS carrier or a carrier with one of the other mutations, beta thalassemia or hemoglobin D, and you are a couple at risk. 1 in 4 of your children can have sickle cell disorder. But if you are not a carrier, but you already have sickle cell disorder, so you are like this, you are homozygous SCS. Okay, your partner could be AA, normal, without hemoglobin S, so there is no problem. All your children will be carriers of hemoglobin S, but without problem. Or your partner is also a carrier of hemoglobin S. In this case, of the probability in each pregnancy is that half of your children are homozygous for hemoglobin S, have the risk to have the disease. Okay, and in this case, sorry. If you are at risk to have the disease, what are your options? You are a couple at risk and you want to have children. What are your options? You want to have healthy children or not? You can adopt a child, or you can do a preconception test. Before you got pregnant, you have the possibility to do in vitro fertilization with pre-implantation genetic screening. So it's a fertilization method when the embryos are taken from the mother, fertilized, and then screened for sickle cell. So the different embryos are screened for sickle cell with molecular methodologies, and the embryos that do not have the sickle cell disorder are selected and implemented again in the mother to give rise of a child. Or you can, if you are already pregnant, you can do a prenatal diagnosis. A prenatal diagnosis is done in the first weeks of the pregnancy, can be done by amniocentesis or chordocentesis. And it's a study when a sample of blood of the fetus, if it was in the chordocentesis, or a sample of amniotic fluid in the amniocentesis is taken, and the DNA of the fetus is extracted from this sample. And after this, with molecular technologies like PCR and Sanger, we detect if the mutations of the parents are present in the fetus, if the fetus is normal, or if the fetus is sickle cell disorder. Okay, here is a resume of the options you have when you are a couple with when you are a couple at risk. This is a reproductive decision making tree that I saw in a paper from Pecker, published in Blood in 2018. And what happens is, if you are a couple at risk, if you are a woman, and if you are a carrier of hemoglobin S, if you are not pregnant yet, you can decide, or you don't want to be pregnant, or yes, you want to be pregnant, you want to have a child. In case you want to have a child, as I said, you have to test your partner. You have to do an hemoglobin electrophoresis, but also in an hemogram. And if both of them are at risk for a sickle cell disorder, you have to then do molecular studies to confirm the mutations. So if it was a couple at risk, if it was not, okay, no problem, you can continue with the pregnancy. But if you are, as I said, you can do the pre-implantation test. Yes, okay, you can do this. You are referred to a reproductive endocrinology, or no, you don't want to do this, but you want to do the amniocentesis for fetal diagnosis. Yes, you want to do the sickle cell test, the prenatal diagnosis, and it's negative. Perfect, you can continue with the pregnancy. But if you do the amniocentesis, and if it was positive, you have two options. Or continue with the pregnancy. And in this case, it's better you talk with the prenatal pediatric hematology because you are going to have a baby with sickle cell disease, or you don't want to continue with pregnancy and you should go to a gynecology to interrupt the pregnancy. You have another option here because you can opt for not to do the pre-implantation test nor the amniocentesis test. So we advise you to screen the newborn because you could have a baby with sickle cell disease, and it's better that we know when he borns. It's possible to screen the newborn to see if he has a disease or not. Okay, and it's the same here. If you are already pregnant, it's the same. You have to study your partner. You have less time, but you have to study your partner. And if you are at risk for SCD, you have the option for a prenatal diagnosis. So at the end, I think that you know now what are your options, but I have to advise you that if you need genetic counseling, you should consult your doctor and the genetic counselor, because only they know your condition and could give you the best advice. And as a take-home message, I would like to say that SCD is a recessive disorder, but the carriers can be identified with an easy and cheap hemoglobin study. If you are at a reproductive age, ask your doctor to do the test. It's easy. And a couple of at risk for SCD have different options to make the right decision. It will always be a personal choice, but it's important to be informed. Okay, and that's all. And now, thank you for your attention. Here is my email if you have questions at the end of after this presentation. And I would like to ask Mary Angela, because I have a small video that I would like to go.
Okay, I hope you enjoyed the video. So I will open now the question and answering session. And as said, you can both write in the chat. I've seen people are already writing, so I will go through the question, but you can also unmute yourself and take part to the debate if you prefer. So I will start saying that I have received in private very good feedback on your presentation, Celeste, because they say it's very clear and such a clear presentation, and I really would echo the same. I think many patients will really benefit also from the video we are going to share. So thank you very much for this. I go to the first comment or question. I don't know, I will read it with you. I have interacted with some sickle cell carriers who experience the same symptoms, crises, and complication like those of us with sickle cell anemia. Before, I also thought sickle cell carriers are asymptomatic.
You finished?
Mm-hmm.
Okay.
It's a comment here. It's
okay. Yes, it's true. I also have this problem because it's true that the sickle cell carriers are asymptomatic and are healthy, but they can have other conditions. And like any other people that have different conditions, they can have a sickle cell trait with everything else. They can have they can be carriers for a membrane disorder or an enzyme disorder, and red blood cell enzyme disorder, then goes to aggravate the phenotype. And in fact, what you see now, we can see with people that work with molecular genetics, is that there are lots of mutations in different genes. In the past, we only saw the mutations in the genes that we are studying, like the HBB gene, but now with the NGS, we study a lot of genes. In fact, there are people that have mutations in different genes. And I think that these carriers, the problem with these carriers that have symptoms is because they should have another mutation in another gene, maybe one gene of the membrane of the red blood cell, or one gene of the enzymes, and the two mutations combined aggravate the phenotype of the sickle cell. But this is only a suspicion, not a confirmation, but that's a study that I think will be done in the future, because in fact there are lots of carriers now that present with symptoms. I don't know if I asked Marianne.
I've seen one comment from the same person that raised the comment before. He said, I will want to talk about the carriers with symptoms. Then I have, thanks, Dr. Bento. My colleagues and I are in the process of developing an HBopathies genetic counseling service, hemoglobinopathies, sorry, genetic counseling service. As you rightly said, with people having partners from across the world, it is now even more likely to see pregnancy that could be combined heterozygous for different hemoglobinopathies alleles. Can you recommend any resources as to how to predict the phenotype severity of such combination that might even be unreported so far in the literature?
Yes, I have the same problem. Because now we see so many different mutations, and it's not easy to know the result of the combination of the mutations. But there are, you can go to the ClinVar. The ClinVar can give you the significance of the mutations. I think EtherNet is preparing. I don't know if you know EtherNet. It was in my slides because of the EtherMaps, but the EtherNet has a lot of information about hemoglobinopathies, and they are preparing one for phenotype. So it will be a good tool in the future to know the phenotype. But for the other cases, it's you have to talk with the doctors, with different people working in the area, because there are no one tool that answer all the questions.
Thank you. So I will go through the other question. Can you simply ask your doctor, GP, your family doctor to be tested for sickle because there is sickle cell in your family? What if they are not willing to do it?
Okay, Miriam, I think the doctors will say yes. I can't imagine a doctor saying no, mostly in the case that there is a carrier in the family. But there are no these tests outside the clinical. There are no these tests in the pharmacy. Could be a good idea to sell this kind of tests and it could be done. But no, the only possibility now is through your doctor to do the test. And at least in Portugal, but I think in the rest of the world is the same.
I am the youngest of 4 children, the only one with sickle cell. One of the other is HPA, adult children who has sickle cell. This shouldn't be possible according to all the presentation and discussion I had on this. Is there an explanation, or will it be a wrong test result?
Okay, there is always an explanation. The father is not a carrier of hemoglobin S. It's the most probable, because if the mother is hemoglobin A, you know for sure that mother is hemoglobin A, or she's a carrier. She can be normal, but she can be a carrier, A and S. One of the hypotheses. The other is that the father can be a carrier, or also it can be a wrong test, but I think that you have also repeated it. I don't know.
If I can speak quickly. Hi, Celeste.
Yes.
Thank you very much.
Hi, Miriam.
This is something that I have asked multiple doctors. I never had a clear answer on that. And because it's not myself, I have recommended repeating the tests, because there are multiple tests. The result was always the same. Neither the father or the mother are carriers. So I would say they are clean. And yet one of the children is a carrier, which is intriguing. So, but the tests are a bit older, but it is a fact. So I was just asking if there is a possibility that, I don't know, some possibility, but okay.
Miriam, the only thing if I can say to you is, if you want to send me the 3 blood samples from the mother, the father, and the child, I can do the test and confirm it. But in my experience, it's almost impossible. But okay, in genetic, I also have learned that we never say impossible, because everything is possible. So, but it's a very strange case.
Okay, thank you.
Thank you. So I think David would love to add something on the previous discussion.
Can you hear me now?
Yes. Perfectly. Go ahead. Yes.
I commented about carriers having the same symptoms. Now, I am sickle cell anemia, hemoglobin SS. I published a book about my experience and then some scientific information in September 2020. And a sickle cell carrier, somebody that has hemoglobin AS, read the book and reached out to me. Her name is Mwakbe Mila. She is in the UK. I'm from Nigeria. I work in Saudi Arabia. And she reached out to me that she read my book, and everything I described in my book are the things she has experienced. Now, in the book, I described about my experience with PICA, my experience with priapism, with chronic fatigue syndrome, with chronic leg ulcer, pain crisis, and some other conditions with sickle cell, complication with sickle cell disorder. And I was arguing with her that it's not possible because I'm a doctor, right from medical school, what I was taught is that as carrier, you are asymptomatic. You don't get to have the same symptoms or crisis or complications. But she said no, that she is carrier. She has done a lot of tests from the doctors in the UK, and it has shown that she's still a carrier, but she still have those crises. At times when she go to complain about crisis, at times when she go to complain about some of the complications, and they don't get to listen to her. So I was like, okay, so if you are experiencing this thing, definitely it is the same thing, because I never knew before then that carriers also experience the same thing. Those of us that have sickle cell anemia experience. So she now started a foundation, is a symptomatic sickle cell traits, which reached out to a lot of people who have sickle cell traits to speak out. And that's how I got to know that in Zambia, Nigeria, and different parts of the world, there are people that are just sickle cell carriers, and they have the same complications, avascular necrosis. In fact, this lady had stroke 2021, because stroke is a risk to sickle cell. Sickle cell disorder can cause stroke. You know, information about sickle cell disorder is evolving, or will I say, information about sickle cell disorder is scanty, because sickle cell disorder, though is the earliest genetic disorder to be identified globally, it is still the least funded and the least researched. Even from my own experience, right from when I was in medical school, I got to know and I was taught that as a sickle cell anemic, if you have sickle cell anemia, the risk of stroke is only in children. But last year, I'm 45 years old. Last year, I did 2 CT scan and MRI of the head, and it showed that I have silent stroke. I've never had before that somebody with sickle cell, adults that have sickle cell anemia can have a risk of stroke. So a lot of things about sickle cell disorder that we knew, I think is like an incomplete information. Then I had to interact with other people. I interacted with an ophthalmologist in Nigeria, above 60. And she said, yes, that she has met people that have sickle cell trait who presented with the same pain crisis and other complications that those of us that have sickle cell anemia. So since then, I've started changing my opinion, and I started listening to a lot of people. In fact, some of the people that from Zambia, when they described their experience, and I was at the forum, Zoom conference, some of them said they went to the hospital to present with pain crisis, but the only thing the doctors gave them was paracetamol or ibuprofen. Did not place them on any medication, did not place them on IV fluid, and they were growing in pain. And the doctors insisted that if you are trait, you cannot have those crises, that they are just complaining of other things. And they had to go back home. And when I had many of them speak, I discovered that there are more than 10 that had experiences presenting in the hospital, and the doctors or the health workers did not listen to them, even though they had to do a repeated sickling test or hemoglobin electrophoresis test or other forms of tests to confirm that they are sickle cell disorder. And this test confirmed that they just have sickle cell trait, but yet they have the same symptoms and complications. So since then, I've started changing my opinion about things we know regarding sickle cell disorder, since it's as if there's so many things about sickle cell disorder that we do not know. This same lady, when I discussed about my experience with chronic fatigue syndrome, she also described having the same symptoms. WHO had a criteria of inclusive criteria to describe chronic fatigue syndrome. And if you check online, you discover any medical journal, you discover that even though there are limited information concerning chronic fatigue syndrome, scarcely will you see any medical journal or literature that says chronic fatigue syndrome occurs in people with sickle cell disorder. But when I had to interact with a lot of people with sickle cell disorder that are adults all over the world, most of them confirm that they have chronic fatigue syndrome, and that the same pattern is that you presented in the hospital and you describe your symptoms or the manifestations, and the doctor thinks you are just joking or you are just lying, and they don't get to listen. So I think we need to be open to understand more about sickle cell disorder, because if you are supposed to work on only what we knew in the past, then it seems as if we may not know as much as possible as regarding sickle cell disorder. Thank you.
Thank you, David. I think it's a very complicated, but okay, you are right. and the problem is because, in fact, sickle cell disease continues to be a silent disorder. It's very frequent in the world, but it's a silent disorder. And that's why this kind of webinars and the meetings are very important to disseminate the information, and more studies are needed to understand all of these different conditions that appear now. Thank you for your testimony.
Yeah, thank you very much. I see Beverly raising hands. You can unmute and have the floor, and I will say, looking the hour will be the last interaction. Can you hear us, Beverly?
Yes, I can. Thank you so much. Can you hear me?
Yes,
yes,
perfectly.
yes.
Thank you.
Yes, I really appreciate the last speaker speaking. I think he kind of talked about a lot of things that I wanted to say, but one of the things that I wanted to ask was how much of it, because I've come to understand that for some of the patients, misdiagnosis is also an issue where, depending on the S content or the ACE content, people are diagnosed as traits when they truly have sickle cell disease. I don't know how much of that you've seen and observed, and if we're missing something in terms of another sickle cell gene that, you know, because I know we have S, we have C, we have E, you know, are we missing something with a lot of these sickle cell patients with, no, sorry, I would say traits, people with traits that are having the symptoms compared to those? Is there any study going on, a trial going on to compare what's going on in that area?
Yes, the hemoglobin gene, the HBB gene, is a very small gene and is very easy to study. So these carriers of hemoglobin S for sure don't have another. If they are studied at molecular level, they don't have nothing in the HBB gene if they are well studied. But as I said, maybe they have mutations in other genes in the red blood cells that are interacting with the hemoglobin S. There are studies ongoing, but at the moment we don't have any date for this. What happens sometimes is that, but I have seen one case only in my life, and it's a very, very rare condition, is that the carriers of hemoglobin S lose the other gene. Lose is because for different mechanisms, the other gene becomes inactive or becomes identical to the hemoglobin S gene, and the person becomes a beta thal major. If you, I have one case in my experience, but it was a carrier in the beginning that at the end it was a beta thal major, but it's not frequent, and for sure it's not what happened with this beta thal hemoglobin S trait that have symptoms. Must be other conditions, but we don't know what they are yet. I hope you have the answer.
Yes, she confirmed in the chat. Thank you very much. So please, I would like to know if G6PD deficiency is an hemoglobinopathy.
Okay, no, hemoglobinopathy refers to disorders of the hemoglobin, and G6PD is a disorder of the enzymes, like I told in the beginning, the enzymes of the red blood cell. But sometimes, as G6PD is so frequent also in Africa as hemoglobin S, sometimes they join both together, but it's not an hemoglobinopathy.
Great, thank you very much. So as I was saying, it has been a really great debate and session. Thank you very much, Celeste.
Thank you,
for being with us and for sharing your time and expertise. has been a very clear and comprehensive presentation. Also, thank to all the audience for having been with us and raised all these important points and bringing testimonies. We really appreciate that. So I hope to see you on the 17th of October for the next session. And well, that's it. Thank you very much.
Bye. Thank you.
Bye-bye.
Thank you.